Well, we know our patients that have triple-negative breast cancer, particularly the ones that are PD-L1 negative, have very aggressive disease. They don't often live that long. It is devastating to sort of be able to only give them one line of therapy and then have them be too sick to do more lines of therapy. I think when we look at claims data, we see there's a substantial amount of patients that don't make it to second line. And I know in our practice, it's hard to think about, but there's a lot of our patients that don't get that second chance.
Yeah, so Reva, like Alison said, attrition is very high.
Yeah.
There is this provocative paper that was published about a year ago that showed about 50% of the patient in the US never make it to a second line. Now, every single doctor will be like, not my patients, but the data speaks for itself. It was a large cohort, 2,000 patients. 2,000 patients, and it shows that if you look across the US, about 50% of the patient never make it to the second line.
Yeah.
Can you tell us a little bit about the field, where we are today, especially in the patients that are PD-L1 negative? How are we treating them today, and how is it changing?
Yeah, I know. I saw that data and I was so surprised by it. And I think you're right. We're all like, not me.
Yeah.
But it is true. I mean, that's really how the landscape of triple negative breast cancer has been. And it's really the only part of breast cancer treatment where we've had very limited targeted treatments available for our patients, right? Chemotherapy is still, well, hopefully not soon, but has been the mainstay of our treatment. So for those patients who are PD-L1 negative, if they don't have a BRCA germline mutation, we really have been limited to chemotherapy for those patients. And that, not only does that mean poor outcomes, but it also means a big impact on quality of life.
Yeah.
So we desperately need better treatments for these patients.
Yeah, for sure. And that's why I was very excited. At ESMO late last year, they presented 2 studies, that really gave us hope for that field. Yeah. They presented the TROPION Breast 02, and they also presented the ASCENT 03 for that specific population, the PD-L1 negatives, which are about 60% of the population. So the majority are going to be PD-L1 negative. So let's start first with the TROPION Breast 02. Alison, can you tell us a little bit about the study design?
So yes, this study was looking at patients that had newly metastatic triple-negative breast cancer. And honestly, in TROPION-02, they could have recurred really quickly after their initial curative therapy. There were a good amount of de novo patients in it, but for those that even had a 0 to 6 month interval, they were allowed in that study. And they were going to be treated with either they're going to be treated either with Datopotamab, Deruxtecan, versus chemotherapy of choice, which of course that included a menu that we might typically think of for our first line patients, taxane, capecitabine, eribulin.
Yeah. So something interesting about that study is that they included those patients that are hyperprogressors. I call them from the early setting, right? This disease-free interval that is between 0 to 6 months. How important is that for you, Reva?
I applaud them for including those patients, because that group of patients is so hard to treat in the clinic. We just don't know what to do with someone who's progressed on our curative, neoadjuvant, adjuvant therapies. And so to include that group of patients that we know is going to have poor outcomes and say, okay, here's an agent that we want to offer to these patients is really, really commendable. And it's great to have data for those patients.
Yeah, because for our audience, historically, those patients are excluded from studies because when they design studies, they want to set it for success. And usually those patients have poor outcomes and are very high risk for nothing to work, actually.
Right.